This is the epidural. The first thing you do is get your patient in the room, get them on the monitors, and tell them you're going to explain to them everything they're going to feel as you're doing it, and you'll tell them everything before you do it. Then you would open your kit and put on your sterile gloves. Well, before I did that, I would feel for landmarks before. So you want to find Two Fears line again. That's on the PSIS, and then you trace it midline, and that should be between L4, L5. And you're having the patient curl their backs like a cat. And so when you think you found that space, you can make a little mark with something. And then you would open your kit, put on your sterile gloves, sterile mask, sterile hat. Sterile hat. Put a hat. And get ready. So the first thing you would have drawn up sterilely using a filter needle, because of these things are all in glass ampules. The first thing you would have is your needle that you're going to use to make the wheel and localize with. So you go back to that spot that you think you're going to go between L4, L3, and you kind of use it to make sure all your anatomy is where you think it's at. If you hit os, you're not in the right spot. So you're making a wheel, and then you're injecting lidocaine as you go and injecting lidocaine as you come out. And you can tell the patient, this will be the worst part, but if you feel me shoot down your right side, let me know. If you feel me shoot down your left side, let me know. And then you redirect your needle in the opposite direction. So you're done localizing. So then the next thing you're going to do is hook up your TUI needle. And the TUI needle is a large bore needle that makes it easier for you to tell the characteristics of the ligaments that you're in. And also it's really wide bore because you have to put a catheter through it. So you have in here saline with a little bubble in it, and we're going to use that to feel when we hit loss of resistance. You can kind of watch the bubble. So you have that wheel localized, that area. You kind of stabilize your left hand right there, right below the needle. And then you go in, and the first thing you're going through is skin. Then you're going through subcutaneous fat, then supraspinous ligament, then interspinous ligament, which interspinous ligament is like 2 or 3 centimeters in, our lecturer said, and it can kind of hold your needle for you. Like, that's how you know you're in the interspinous ligament. It's firmer, and it'll even hold your needle up for you. And then once you go past that, you'll be at the ligamentum flavum, which is like 4 to 6 centimeters in there, 4 centimeters or so. And it's going to feel gritty. And it's here that you're going to start doing little, like, 1 millimeter pops as you advance. And when you feel a loss of resistance, you're just going very, very gently, very, very gently. When you feel a loss of resistance, you'll feel it, and it'll suck a little saline and move your bubble in your syringe. You don't want any air to go into the patient, but it's nice to be able to watch the bubble. And it's okay if a little saline gets sucked into that epidural space because it's a negative pressure in that space. So then, once you know you're in the right area, and you went in bevel up with your TUI needle because you want the epidural catheter to direct upwards. So once you think you're in the right spot, you take this out. I guess you could aspirate just to make sure you're not in CSF and be like, okay, yeah, negative CSF, negative blood. And then you would take that out and it'll stay right there. And then you're going to put your catheter in next. So, you thread this in all sterilely. And the first big hashtag on the catheter means that you're at 5 centimeters. And then the next one, like the next double hashtag, means you're at 10 centimeters. And the TUI needle is only 9 centimeters long, so you want to go about 4 centimeters like twirled up into the epidural space. So you would calculate, you know, how the depth of your patient on your TUI syringe and know that you have to go that many beyond it just to get your catheter like 4 centimeters up into the space. So once you think you're in the right place, there'd be a drape here, so this would be sterile, so we're going to let that fall. you have to be really careful when you're doing this because you're going to be removing your TUI needle now. So you got to be careful that you don't pull out from where you are in the epidural space with your catheter. So you're just lightly, a little bit at a time, a little bit at a time, coming out, making sure it's at the right centimeter depth and you get it all the way out. Okay. All right. All right. So now your catheter should be threaded 4 centimeters into the epidural space. Now the next thing you're going to have is your test dose syringe, and this syringe contains 1.5% lidocaine, 3 milliliters of that, mixed with 1 to 200K epi, so that the total in the syringe would be 45 milligrams of lidocaine and 15 micrograms of epi. And you're going to attach your little connector. There's like a blue connector thing that goes here. And you're going to give your test dose, but before you give your test dose, you're going to make note of the heart rate and tell the patient that if you start to feel numb anywhere, please let me know. If you hear ringing in your ears or if your mouth starts to like taste funny or feel numb, let me know. So this test dose uses the lidocaine to test if you are in the subarachnoid space, which you don't want to be in because then that's a spinal. And it also uses the epi to test if you're in the intravascular space, which you don't want to be because then you can give your patient local anesthetic toxicity and they might die. So when you hook up this test dose, you aspirate and you're looking for blood or CSF. And then if that's negative, you can inject the test dose. And then, so you're watching your monitor because you already know what your heart rate is before you give the test dose. And you watch the monitor for 3 minutes and you talk to the patient. And if the heart rate goes up 20 to 40 beats per minute, and our lecturer said in the first 30 seconds, but you're watching for 3 minutes anyways, then that's a positive test dose that you were in an intravascular space. And also, when you do that first aspiration, and all aspirations with these procedures, you want to do it really, really gently because you can collapse an epidural vein and you can think that you're not in the intravascular space, but really you are. So if your test dose is positive, you'll see your heart rate go up and you'll see your patient might have a sense of doom, someone told me one time. And also if you're in the subarachnoid space, then your patient would start to feel numb, or they could feel like a numbness in their mouth, a ringing in their ears. They would start to feel numb in their legs, and you would know you weren't in the right spot, so you'd have to abandon this and pull everything out. So if it's not negative, though, after you've been watching for 3 minutes, then you're done with this syringe, and you would give your bupivacaine. So you would dose your bupivacaine or ropivacaine, depending on whatever local anesthetic your hospital uses. And in our lecture, we talked about giving a total. If you're doing an epidural, you would do like. What did he say? He said, this is like, he called this his like heavy, like this is like his recipe. He aspirates and injects 3 milliliters of 0.25% bupivacaine, waits 5 minutes, aspirates and injects 3 milliliters of 0.25% bupivacaine, waits 5 minutes, aspirates and injects 3 milliliters of 0.25% bupivacaine. And then, so he's watching a patient for a total of 20 minutes and assessing them, and you get vital signs every 2 minutes for the first 15 minutes, and vital signs every 5 minutes for the next 15 minutes. And I forgot what I was talking about. But then you would start like a bupivacaine drip or whatever your institution uses. You can lie the patient flat after they get the epidural in, but before you do that, you would secure the epidural with that square thing, and then you like tape it down really good, and then you kind of tape it up and around their shoulder like that so it stays in its spot. And you have to mark this with, you know, like epidural catheter so no one confuses it with anything else. And that's pretty much it. Thank you.